Welcome back. Now that we've covered the prognostic landscape in cardiac amyloidosis, it's time to shift our focus toward what truly changes outcomes: treatment. In this lesson, we'll walk through the major milestones and emerging strategies in the therapeutic management of transthyretin cardiac amyloidosis. Until recently, treatment was largely limited to supportive care or organ transplantation in select cases. For hereditary forms, ATTR-V, liver transplant was once the only disease-modifying option. And for ATTR-CM, whether wild-type or variant, no targeted therapies were available at all. But the landscape has shifted. Over the past decade, scientific advances have revolutionized our ability to intervene at multiple points along the amyloidogenic pathway, from stabilizing the transthyretin protein to silencing its production and even targeting existing fibrils for removal. This figure offers a high-level view of these strategies. Stabilizers like tafamidis and diflunisal work to prevent TTR tetramers from dissociating. Silencers, including RNA interference, siRNA, antisense oligonucleotides, ASO, and gene editing platforms, reduce hepatic TTR synthesis at the genetic level. Depleters, such as monoclonal antibodies, aim to clear existing amyloid deposits, though this approach remains investigational. Tafamidis, the first drug approved for a ATTR-CM in 2019, marked a watershed moment in treatment. Since then, research has accelerated rapidly, with dozens of trials underway investigating both new stabilizers and next-generation gene therapies. Alongside disease-modifying agents, supportive care remains essential, especially in managing symptoms of restrictive cardiomyopathy and heart failure. This figure outlines the staging and therapeutic goals across the ATTR-CM continuum. Most patients are diagnosed late, often at stage C or D when symptoms are advanced. This highlights the urgent need for both early detection and appropriate intervention to delay progression and improve quality of life. By the end of this lesson, you'll have a comprehensive understanding of how to align treatment strategies with disease stage, genetic subtype, and patient-specific factors. Let's begin with supportive treatment strategies for cardiac involvement in ATTR amyloidosis. Managing heart failure in transthyretin cardiac amyloidosis requires a nuanced approach. The combination of restrictive ventricular filling, low cardiac output, and frequent autonomic dysfunction makes this population uniquely sensitive to standard heart failure therapies. First, volume management. The primary therapeutic objective is to achieve euvolemia without exacerbating hypertension or compromising renal perfusion. This starts with non-pharmacologic strategies, a sodium-restricted diet, less than 2 grams per day, and fluid restriction to 1.5 liters daily. Patients should perform daily weight checks to monitor for early signs of fluid retention. Loop diuretics, particularly torsemide and bumetanide, are preferred over furosemide due to better absorption. These are often combined with aldosterone receptor antagonists to enhance natriuresis and preserve potassium levels. That said, volume management can be precarious due to small left ventricular cavity size and autonomic instability, which increase sensitivity to preload changes and medications. Loop diuretics, particularly torsemide and bumetanide, are preferred over furosemide due to better absorption. These are often combined with aldosterone receptor antagonists to enhance natriuresis and preserve potassium levels. That said, volume management can be precarious due to small left ventricular cavity size and autonomic instability, which increase sensitivity to preload changes and medications. Medication cautions. Let's now review medications that are poorly tolerated or should generally be avoided in patients with transthyretin cardiac amyloidosis. First, we have ACE inhibitors, angiotensin receptor blockers, ARBs, and angiotensin receptor neprilysin inhibitors, ARNI. These agents are often poorly tolerated due to hypertension, and their benefit has not been established in ATTR-CM. Next, beta blockers. These are also often poorly tolerated, particularly in patients with low stroke volume. The main risks include bradycardia and hypertension. Non-dihydropyridine calcium channel blockers, such as verapamil, are strictly contraindicated. They are associated with hypertension and conduction disturbances. Dihydropyridine calcium channel blockers are generally discouraged as they may contribute to hypertension in amyloid patients, though this varies slightly by source. Finally, digoxin is considered relatively contraindicated. If used, it should be administered at very low doses and only with close monitoring due to the risk of toxicity in amyloid-infiltrated myocardium. These cautions are essential for optimizing patient safety in the management of ATTR-CM. Disease progression and cardiorenal syndrome. As ATTR-CM advances, the ventricular cavity shrinks, reducing stroke volume and cardiac output, often leading to cardiorenal syndrome. This limits the ability to titrate diuretics and further complicates management. In selected patients with refractory symptoms and preserved extracardiac function, heart transplantation may be an option. The role of ventricular assist devices remains limited, given the anatomical and hemodynamic constraints posed by restrictive cardiomyopathy. Patients with ATTR-CM often develop arrhythmias, most commonly atrial fibrillation (AF), which worsens symptoms due to dependence on atrial contraction for ventricular filling. Rhythm control is preferred over rate control to preserve cardiac output. Amiodarone is the first-line agent due to its low risk of hypertension and bradycardia. In early disease, electrical cardioversion or catheter ablation may help restore sinus rhythm, though recurrence rates are high, around 50% at 1 year. Lifelong anticoagulation is essential in all patients with AF, even when CHA2DS2-VASc scores are low. This is due to a high prevalence of intracardiac thrombi despite adequate anticoagulation. For bradyarrhythmias and conduction disease, pacemakers are often required. Increasing the lower pacing rate can improve symptoms in patients with hypertension or low output. Cardiac resynchronization therapy, CRT, should be considered in those with a high right ventricular pacing burden, as it may reduce mitral regurgitation and prevent further decline in left ventricular function. ICDs and sudden cardiac death. Although sudden cardiac death is less common in ATTR-CM than in AL amyloidosis, implantable cardioverter defibrillators, ICDs, may be considered for secondary prevention, in line with current AHA, ACC, HRS, and ESC guidelines. Valvular disease considerations. Calcific aortic stenosis, AS, frequently coexists with wild-type ATTR, especially in older men with low flow gradients and mildly reduced ejection fraction. In this setting, transcatheter aortic valve replacement, TAVR, is generally favored over surgical replacement due to lower procedural risk and improved tolerance. Less is known about mitral and tricuspid valve involvement, though limited case series suggest that percutaneous mitral repair, PMVR, may be feasible in selected patients. Tricuspid regurgitation is usually secondary to right ventricular dilation and not often targeted directly. A successful management strategy for ATTR-CM requires integration of lifestyle changes, cautious pharmacology, rhythm preservation, and procedural interventions when needed. Recommended strategies. 1. Supportive care. Low sodium diet, less than 2 grams per day. Water restriction, maximum 1.5 litres per day. Daily weight monitoring, and compression stockings. 2. Pharmacologic interventions. Loop diuretics, for example, torsemide, bumetanide, aldosterone receptor blockers, midodrine for symptomatic hypertension, amiodarone for rhythm control in atrial fibrillation, and anticoagulation, either direct oral anticoagulants, DOAC, or vitamin K antagonists, VKA. 3. Device and advanced therapies. Implantable cardioverter defibrillator, ICD, ventricular assist devices, VADs, permanent pacemaker, PPM, cardiac resynchronization therapy, CRT, heart transplant, and heart-liver transplant. Therapies to avoid or use with caution. ACE inhibitors, ARBs, also called AIIRA, and ARNI, beta blockers, non-dihydropyridine calcium channel blockers, for example, verapamil, dihydropyridine calcium channel blockers, and digoxin. These lists reflect clinical guidance for managing patients with transthyretin cardiac amyloidosis, with a focus on maintaining hemodynamic stability and avoiding drugs that may worsen conduction abnormalities or hypertension. In summary, managing heart failure and arrhythmias in ATTR-CM requires clinical precision. The disease demands tailored strategies that minimize harm, maximize function, and remain adaptive to the disease stage. TTR-specific disease-modifying therapies. Now that we've covered supportive therapies and heart failure management in transthyretin cardiac amyloidosis, let's shift our focus to disease-modifying treatment strategies. These are therapies specifically designed to alter the course of a TTR amyloidosis rather than merely manage symptoms, and are categorized based on their mechanisms of action: stabilizers, silencers, gene editing agents, and depleters. We begin with TTR stabilizers, the current standard of care for treating ATTR cardiomyopathy. These drugs work by binding to the TTR tetramer, preventing its dissociation and the subsequent formation of amyloid fibrils. Let's take a closer look at tafamidis, currently the leading therapy for transthyretin cardiac amyloidosis. Mechanism of action. Tafamidis works by stabilizing the transthyretin, or TTR, tetramer. This stabilization prevents the dissociation of TTR into monomers, which is the first step in the amyloid formation process. Stage of approval. It is approved for both transthyretin-related cardiomyopathy, a TTR-CM, and polyneuropathy, a TTR-PN. Indications. Clinically, tafamidis is indicated specifically for cardiomyopathy due to transthyretin amyloidosis. Route of administration. It is administered orally. Dosing. The approved dosing is either 61 mg of Vindamax or 80 mg of Vyndaqel taken once daily. Clinical evidence, Phase 3, trial. The key evidence comes from the ATTR-ACT trial, cardiovascular outcomes. This randomized controlled trial showed that tafamidis significantly reduced the hierarchical composite of all-cause mortality and cardiovascular-related hospitalizations. Additionally, there were slower declines in functional capacity as measured by the 6-minute walk test and quality of life scores from the Kansas City Cardiomyopathy Questionnaire. Side effects. Notably, tafamidis was not associated with any major side effects. Now let's explore diflunisal, another transthyretin stabilizer used in the treatment of a TTR amyloidosis. Mechanism of action. Like tafamidis, diflunisal works by stabilizing the transthyretin tetramer, helping to prevent its dissociation into monomers, which ultimately halts amyloid fibril formation. Stage of approval. Diflunisal is approved as a non-steroidal anti-inflammatory drug, or NSAID. However, its use in transthyretin amyloidosis, both for cardiomyopathy and polyneuropathy, is considered off-label. Indications. It has been used for patients with both neuropathy and cardiomyopathy due to ATTR. Route of administration. Diflunisal is administered orally. Dose. The standard dose is 250 milligrams taken twice daily. Clinical trials. There are no Phase 3 clinical trials completed for diflunisal in this indication. Cardiovascular outcomes. Despite the lack of large randomized trials, small retrospective studies have shown an association between diflunisal use and reduced mortality in patients with ATTR. Side effects. That said, diflunisal is not without risks. Reported side effects include fluid retention, gastrointestinal bleeding, and renal dysfunction, important considerations for patients with cardiac or renal compromise. Now let's turn our attention to AG10 or acoramidis, a promising transthyretin stabilizer currently in development. Mechanism of action. Acoramidis works by stabilizing the transthyretin tetramer to prevent dissociation, aiming to halt the cascade that leads to amyloid fibril formation. Stage of approval. It has not yet been approved and is still under clinical investigation. A formal review by the US Food and Drug Administration is pending. Indications. Acoramidis is not yet commercially available and is currently being evaluated through clinical trials for the treatment of transthyretin-related cardiomyopathy. Route of administration. This investigational drug is administered orally. Dose. The studied dose is 800 milligrams taken twice daily. Phase 3 clinical trial. The pivotal Phase 3 trial is known as the ATTR-CM study. Cardiovascular trial outcomes. Results from this randomized controlled trial demonstrated significant reductions in a broad range of endpoints, including all-cause mortality, cardiovascular hospitalizations, NT-proBNP levels, 6-minute walk distance, and decline in quality of life as measured by the Kansas City Cardiomyopathy Questionnaire. Side effects. Notably, no major side effects have been reported in the trial to date. 2. Gene silencers and gene editing therapies. Transthyretin, TTR, silencers are therapeutic agents designed to reduce intrahepatic production of TTR by preventing the transcription or translation of its messenger RNA, mRNA. Given that the circulating TTR amyloid precursor protein is synthesized in the liver and encoded by a single gene, ATTR amyloidosis serves as an ideal model for targeted gene interference approaches. These gene silencing strategies operate via 3 distinct mechanisms. 1. Small interfering RNA-cRNA agents, which include patisiran, vutrisiran, and vutrisiran. These molecules bind to TTR mRNA and trigger its degradation through the RNA-induced silencing complex, RISC, effectively reducing TTR protein synthesis. 2. Antisense oligonucleotides, ASOs, such as inotersen and eplontersen, which hybridize with TTR mRNA to facilitate its degradation via RNase H-mediated cleavage, also resulting in reduced TTR production. 3. Gene editing exemplified by CRISPR-Cas9-based therapies which permanently modify the TTR gene to halt its expression. Each approach holds promise in altering the natural history of a TTR amyloidosis by targeting the source of amyloidogenic protein production rather than solely addressing the downstream effects. Let's take a closer look at patisiran, one of the key RNA silencing therapies developed for transthyretin amyloidosis. Mechanism of action. Patisiran is a small interfering RNA, or siRNA, that targets transthyretin messenger RNA. By binding to this genetic material, it prevents the liver from producing the misfolded TTR protein that forms amyloid deposits. Stage of approval. Currently, patisiran is approved for the treatment of hereditary ATTR-related polyneuropathy, but it is not yet approved for cardiac amyloidosis. Indications. Its main indication is for patients with neuropathy associated with hereditary transthyretin amyloidosis. Route of administration. Patisiran is delivered through intravenous infusion. Dose. The infusion is given once every 3 weeks and takes about 80 minutes. For patients weighing 100 kilograms or less, the dose is 0.3 milligrams per kilogram of body weight. For patients weighing more than 100 kilograms, the dose is 30 milligrams. Phase 3 clinical trial. The Apollo B trial assessed the impact of patisiran on functional outcomes. Cardiovascular trial outcomes. In this randomized controlled trial, patisiran demonstrated a slower rate of decline in 6-minute walk test performance when compared with placebo. It also showed reduced decline in quality of life, as measured by the Kansas City Cardiomyopathy Questionnaire. Side effects. Reported adverse effects include infusion-related reactions, vitamin A deficiency, and peripheral edema. Now let's review vutrisiran. This is another RNA silencing agent designed to target transthyretin production at the source. Mechanism of action. Vutrisiran is a small interfering RNA that binds to transthyretin messenger RNA and promotes its degradation, leading to reduced TTR protein synthesis. Stage of approval. It has received approval for hereditary transthyretin amyloidosis with polyneuropathy, but it is not currently approved for cardiac amyloidosis. Indications. Vutrisiran is indicated for neuropathy in patients with hereditary ATTR. Route of administration. It is administered via subcutaneous injection. Dose. Patients receive a 25 mg injection every 3 months. Phase 3 clinical trial. The Helios B trial evaluated the safety and efficacy of vutrisiran in cardiac amyloidosis. Cardiovascular trial outcomes. The trial demonstrated a significant reduction in the combined endpoint of all-cause mortality and recurrent cardiovascular events, both in the full study population and in those treated with monotherapy. Additional benefits included a slower decline in 6-minute walk distance and Kansas City Cardiomyopathy Questionnaire scores. Side effects. Reported adverse effects include infusion-related reactions, vitamin A deficiency, nasopharyngitis, headache, urinary tract infections, and dyslipidemia. Let's take a look at eplontersen, another RNA targeting therapy advancing through clinical development for transthyretin amyloidosis. Mechanism of action. Eplontersen is an antisense oligonucleotide, or ASO, designed to inhibit transthyretin production. It works by binding to TTR mRNA and triggering its degradation, thereby reducing the synthesis of the amyloidogenic protein. Stage of approval. Currently, eplontersen is approved for use in hereditary ATTR with polyneuropathy. However, it is not yet approved for cardiac amyloidosis. Indications. Its primary indication at this time is neuropathy associated with hereditary transthyretin amyloidosis. Route of administration. Eplontersen is administered via subcutaneous injection. Dose. The recommended dose is 45 mg once monthly. Phase 3 clinical trial. The CARDIO-TRANSFORM study is a large Phase 3 randomized controlled trial designed to assess the efficacy of eplontersen specifically in patients with cardiac amyloidosis. The trial is ongoing, with results expected in 2025. Side effects. So far, the most commonly reported side effects include headache and vitamin A deficiency. Now let's look at inotersen, a gene-silencing therapy used in transthyretin amyloidosis. Mechanism of action. Inotersen is an antisense oligonucleotide, or ASO, that binds to TTR mRNA and promotes its degradation. This action effectively reduces production of the transthyretin protein in the liver. Stage of approval. It is approved for a TTR polyneuropathy, but not yet for cardiac involvement, a ATTR-CM. Indications. Current use is limited to neuropathy due to transthyretin amyloidosis. Route of administration. Inotersen is given by subcutaneous injection. Dose. The standard dose is 284 mg administered weekly. Phase 3 clinical trial. The pivotal data come from a Phase 3 randomized, double-blind, placebo-controlled trial. Patients were assigned in a 2-to-1 ratio to receive weekly injections of 300 mg inotersen or placebo over 15 months. Side effects. There are several key safety concerns. Thrombocytopenia and glomerulonephritis require close monitoring. Other side effects include infusion-related reactions and vitamin A deficiency. Now let's turn to a groundbreaking investigational therapy, NTLA-2001. Mechanism of action. NTLA-2001 represents the first in-human application of CRISPR-Cas9 gene editing for transthyretin amyloidosis. This therapy directly edits the TTR gene, aiming to permanently silence its expression and halt production of the pathogenic protein at the source. Stage of approval. NTLA-2001 is currently under investigation and not yet approved for clinical use. Indications. It is being developed for transthyretin amyloidosis, with a focus on systemic disease including cardiac involvement. Route of administration. NTLA-2001 is delivered as a single intravenous infusion. Dose. In early studies, it has been administered at either 0.1 mg per kilogram or 0.3 mg per kilogram as a one-time treatment. Phase 3 clinical trial. There is no Phase 3 trial yet. However, a small Phase 1 trial has demonstrated both safety and a sustained knockdown of circulating TTR levels, marking an important proof of concept for gene editing in human disease. Side effects. Reported side effects so far include headache and vitamin A deficiency, a common concern across TTR-lowering agents. 3. Anti-ATTR amyloid therapies. The therapeutic approach for a ATTR-CM is evolving, with TTR depleters emerging as a promising class of agents targeting the pathological accumulation of amyloid deposits using immunotherapy, particularly monoclonal antibodies. These therapies promote antibody-mediated clearance of amyloid deposits, where antibodies tag the deposits for removal by the immune system, primarily through macrophages. This process aims to deplete existing amyloid deposits in tissues, thereby mitigating disease progression and improving cardiac function. PX004. A therapy currently under investigation that targets misfolded transthyretin amyloid. Mechanism of action. PX004 is a humanized immunoglobulin G antibody designed to bind transthyretin amyloid deposits. It supports the removal of amyloid from tissues by harnessing the body's immune system. Stage of approval. At this time, PX004 remains under investigation and is not yet approved for clinical use. Route of administration. The treatment is administered as an intravenous infusion. Dose. In Phase 1 studies, participants received 4 weekly infusions, with doses ranging from 0.1 to 3.0 mg per kilogram of body weight. Phase 3 clinical trial. There is currently no Phase 3 trial underway. Cardiovascular trial outcomes. A small Phase 1 trial has demonstrated that PX004 is safe, with no major safety signals reported so far. Side effects. The side effect profile remains unknown, pending results from larger studies. Next, let's take a look at NI006, another investigational therapy focused on removing amyloid deposits in transthyretin cardiac amyloidosis. Mechanism of action. NI006 is a recombinant human monoclonal immunoglobulin G1 antibody that binds directly to ATTR amyloid. By tagging these deposits, it facilitates their clearance through immune system activation. Stage of approval. NI006 is currently under investigation and not yet approved for clinical use. Route of administration. The therapy is delivered via intravenous infusion. Dose. In the Phase 1 trial, participants received 4 weekly infusions, with doses ranging from 0.3 to 60 mg per kilogram of body weight. Phase 3 clinical trial. A Phase 3 trial is planned and will assess the efficacy of NI-006 in a TTR cardiac amyloidosis, with anticipated completion by 2028. Cardiovascular trial outcomes. Data from the early phase trial showed that NI-006 is safe, and at higher doses, it appeared to reduce levels of NT-proBNP, troponin 1, and myocardial extracellular volume, all important markers of cardiac stress and amyloid burden. Side effects. Reported side effects include arthralgia and thrombocytopenia. Let's now examine AT-02, another investigational agent targeting transthyretin cardiac amyloidosis through a novel mechanism. Mechanism of action. AT-02 is a pan-amyloid removal technology. It utilizes a single-chain fusion protein specifically designed to stimulate immunological clearance of amyloid deposits. This immunotherapeutic approach targets misfolded protein accumulation directly. Stage of approval. AT-02 is currently under investigation and has not yet been approved for clinical use. Route of administration. The drug is delivered via intravenous infusion. Dose. At this stage, dosing information is not yet available. Phase 3 clinical trial. There is no Phase 3 data currently available. A small Phase 1 trial is ongoing to evaluate safety and initial efficacy. Cardiovascular trial outcomes. Clinical outcomes have not yet been published, as the study is still in progress. Side effects. As of now, the safety profile remains unknown. Combined treatment in transthyretin cardiac amyloidosis. In the evolving landscape of transthyretin cardiac amyloidosis management, one of the most compelling frontiers is combination therapy, targeting multiple points in the amyloidogenic pathway simultaneously. The rationale is simple yet powerful. While individual therapies have demonstrated effectiveness, combining them could potentially offer additive or even synergistic benefits by addressing both the source of amyloid formation and its stabilization in circulation. For example, gene silencers and gene editing technologies aim to suppress hepatic production of transthyretin, TTR. However, even with the most advanced silencers or CRISPR-based approaches, the knockdown of circulating TTR is often incomplete, typically around 80 to 90%. In some patients, this reduction is even less. As long as residual TTR remains in the bloodstream, there remains a risk for ongoing misfolding and fibril deposition. To summarize the current clinical trial landscape for combination therapy, this table outlines participant numbers and the extent of tafamidis co-administration in 4 major studies. Additional therapies and nutritional supplements in a ATTR-CM. While pharmacologic and disease-modifying therapies remain the cornerstone of ATTR-CM treatment, interest continues to grow around the potential role of natural compounds and supplements. Among these, turmeric and epigallocatechin 3-gallate, EGCG, a major catechin in green tea, have garnered attention for their biochemical effects on transthyretin, TTR aggregation. Although neither has been approved as a therapeutic agent, they are widely available over the counter and are commonly used by patients as complementary interventions alongside standard care. Curcumin, the active polyphenol component in turmeric, has shown promise in preclinical models of transthyretin amyloidosis. In vitro studies, curcumin at physiologically achievable doses significantly reduced TTR aggregate-induced stress responses, including endoplasmic reticulum, ER stress, and apoptosis. The proposed mechanism involves tetramer stabilization and prevention of toxic fibril formation, either by inhibiting misfolding or promoting formation of non-toxic aggregates. Curcumin is evaluated in familial amyloidotic polyneuropathy (FAP) mouse models, demonstrating selective binding of curcumin to the thyroxine binding site of TTR. This interaction stabilized the tetramer and reduced TTR tissue deposition by up to 70% in certain organs. The most effective concentration observed was 1 micromolar. Interestingly, no increase in macrophage-mediated clearance was seen at higher concentrations, suggesting a threshold effect. These findings offer compelling mechanistic rationale, but human clinical trials remain lacking. Consequently, curcumin is not currently recommended as a standalone treatment, but may be used by patients as an adjunct with proper medical oversight. Epigallocatechin 3-gallate, EGCG, is a naturally occurring catechin found in high concentrations in green tea. Like curcumin, it has demonstrated anti-amyloidogenic properties in vitro, where it can inhibit the formation of TTR amyloid fibrils. In a small observational study involving 19 patients with ATTR-CM, participants consumed green tea or green tea extracts over a 12-month period. Echocardiographic follow-up showed no progression in left ventricular, LV, wall thickness or myocardial mass. In the subgroup evaluated via cardiac magnetic resonance imaging, CMR, a mean reduction in LV mass of 12.5% was observed, suggesting a potential slowing of disease progression. However, these early findings were not confirmed in a larger retrospective analysis by Capel et al., published in 2020, which evaluated 65 patients taking 675 milligrams of EGCG daily. Over a minimum follow-up of 9 months, no mortality benefit was demonstrated compared to placebo. Nevertheless, the study reported no major safety concerns, confirming that EGCG is generally well tolerated. Despite the appealing safety profile, there remains no clinical evidence that EGCG improves survival or alters long-term outcomes in a TTR-CM. As such, its use should be considered experimental and not a substitute for proven therapies. Although curcumin and EGCG exhibit promising biological activity against TTR aggregation, their role remains adjunctive. Until further evidence from robust clinical trials becomes available, these compounds should not replace established, disease-modifying therapies, but may be considered cautiously under physician guidance in informed patients seeking integrative approaches. Let's summarize the clinical approach to treating transthyretin cardiac amyloidosis. Once transthyretin amyloidosis is confirmed, treatment should be guided by a three-pronged approach: management of heart failure, management of arrhythmias, and initiation of disease-modifying therapy. Let's begin with heart failure. Unlike conventional cardiomyopathies, standard heart failure medications, such as ACE inhibitors, ARBs, ARNIs, beta blockers, and aldosterone antagonists, have not shown consistent clinical benefit in patients with ATTR amyloidosis. In fact, these therapies may cause more harm than good due to low stroke volume and autonomic dysfunction. Instead, focus should be placed on bioavailable loop diuretics, like torsemide or bumetanide, to manage congestion. In patients with stage D heart failure, heart transplantation may be considered if extracardiac function remains preserved. Next, disease-modifying agents. These therapies aim to alter the course of the disease by either stabilizing the transthyretin protein or reducing its production. For wild-type ATTR cardiomyopathy, the approved treatment is tafamidis, with diflunisal available for off-label use. In hereditary ATTR, treatment selection depends on the type of organ involvement. If the patient presents with cardiomyopathy alone, options include tafamidis or off-label diflunisal. In patients with both cardiomyopathy and neuropathy, combination therapy may be necessary. Agents like inotersen, patisiran, and tafamidis are used, with diflunisal again considered off-label. For those presenting solely with neuropathy, inotersen and patisiran are the mainstays, and diflunisal remains an alternative. These therapies work through TTR stabilization or gene silencing to reduce amyloid formation at its source. Arrhythmia management is also critical. From a medical standpoint, atrial fibrillation is addressed with rate or rhythm control, and procedures like cardioversion or catheter ablation may be considered. Importantly, lifelong anticoagulation with DOACs or VKAs is strongly recommended for all patients with atrial fibrillation, regardless of their CHA2DS2-VASc score, due to the high risk of thromboembolism. In terms of device therapy, permanent pacemakers should be placed for conduction disease or AV block. Implantable cardioverter defibrillators, or ICDs, may be considered in selected patients with ventricular arrhythmias or aborted sudden cardiac death. Cardiac resynchronization therapy, or CRT, may also be appropriate for pacemaker-dependent patients with reduced ejection fraction. To summarize, the treatment of cardiac amyloidosis is multidimensional. It requires tailored strategies to manage heart failure, correct arrhythmias, and address the underlying disease process with disease-modifying agents. As therapies evolve and awareness increases, earlier diagnosis and effective treatment will continue to improve outcomes for patients living with this challenging condition. In the next lesson, we'll turn our attention to the essential topic of follow-up of patients with a TTR cardiac amyloidosis, where we'll explore optimal monitoring, timing of treatment reassessment, imaging intervals, and tracking response to therapy. See you there!